Hello and welcome. We are here at the ASHupdate 2012 in Zurich. Next to me is Steve Schuster. He's the Director of the Lymphoma Program and Translational Research Program from the Abramson Cancer Center in Pennsylvania. And he will talk to us about the new and interesting data regarding follicular lymphoma and CLL, and also, very important for me, the clinical implications. Now, Steve, you mentioned an American trial with bendamustine in follicular lymphoma. We just heard the very interesting Rommel data at the ASCO, and it set in a way a new standard. So, and there's now an American trial which showed what?
It at this point shows very similar results in terms of response rates. In that the BRIGHT trial, which is the trial you're referring to that was presented by Ian Flynn, showed that R-CHOP versus bendamustine Rituxan had very much the same complete response rates and overall response rates in indolent lymphomas. But what I think was interesting, mantle cell lymphomas in that trial had a much higher CR rate than indolent lymphomas. The CR rate was about 50% as opposed to like about 25-30% for indolent lymphomas. So it looks like mantle cell lymphoma is particularly suited to the bendamustine Rituxan regimen. But yeah, this trial will allow us to see whether the progression-free survival that Rommel has presented holds up in a separate cooperative group trial, which is equally large.
Okay, so there was a clear benefit for bendamustine, for the addition of bendamustine by PFS from the Rommel trial, but PFS was not yet.
The BRIGHT trial is not mature enough to really conclude whether or not there'll be a difference or an advantage in progression-free survival for either arm. Clearly, the adverse events were different in each arm. There was much more neutropenia, obviously, in the arm that had R-CHOP, RCVP, as opposed to R-bendamustine. There were somewhat more infusion reactions in the R-bendamustine arm. So there were differences related to adverse events and tolerability that were clear, but response rates were about the same. So R-bendamustine and R-CHOP, RCVP were equivalent with regard to response rates. But the real issue is the progression-free survival. So we'll want those data to mature more and see how they match with the data that Rommel presented. But it appears in the United States as well as in Europe that bendamustine Rituxan is becoming the frontline regimen for low-grade follicular lymphomas and other indolent lymphomas as well.
So you're using it already in the treatment?
Yes, I personally am in my practice, and I know many physicians have switched primarily because of the toxicity profile. It's much easier than R-CHOP to administer. There's no neuropathy. The myelosuppression is not as severe, and the impression is that although in the BRIGHT trial that looked more or less equivalent, the impression among many is that the CR rate may be slightly better with bendamustine Rituxan.
Okay, so you give it for 6 cycles, or how long do you give it?
I generally give it 6 cycles as maximum. In the BRIGHT trial, I think they gave 6 to 8. I'm not sure. I'd have to look to see what the average number that were actually delivered, but 6 cycles, which is what I think
the Rommel
trial.
As far as I can remember, yes. So 6 cycles, and then you make a break.
Well, there's the whole issue of maintenance Rituxan, which is being studied right now, and we'll have data, I think, from Rommel in the Still group. There are data from the PRIMA trial showing us that progression-free survival is improved with maintenance Rituxan, and despite the fact that there was no overall survival difference in that study, many are using maintenance Rituxan after induction therapy in follicular lymphoma and some other low-grade lymphomas. So I have to say, in the absence of data, I have used maintenance Rituxan, but discuss it with patients, discuss the absence of data following bendamustine Rituxan, and make it clear that we're waiting for those data to be available.
And you give it in analogy to the other trials for 2 years, every 2 to 3 months?
Right, every 2 to 3 months.
Okay. So that's interesting. Well, that's very very clinically relevant. I mean, so that's how you treat. Are there some patients you do not treat with bendamustine now?
There are. So some follicular lymphoma is histologically sometimes a very heterogeneous disease. You may biopsy the bone marrow and see grade 1 lymphoma, biopsy one lymph node and see grade 2, predominantly follicular architecture lymphoma, biopsy another node and see follicular grade 3 or even diffuse large B-cell lymphoma. So it can be very heterogeneous. When I'm evaluating a patient with follicular lymphoma, I usually, as part of my staging, do a PET CT scan and try to biopsy the most FDG-avid lymph node, and to make sure that I'm not dealing with a follicular lymphoma in transformation or a grade 3 follicular lymphoma. In those cases, if there's transformation or a large cell component, I'll treat with R-CHOP. But if I don't have a biopsy showing large cell lymphoma, if a patient presents with a non-biopsyable, very FDG-avid tumor with a high serum LDH, for example, that patient I may presumptively treat with R-CHOP, thinking that there's transformation there.
Okay, but a less intensive or another regimen is not frontline for you in any consideration?
Not true. Rarely. I think that in elderly patients, there are patients that will not accept chemotherapy. I think that Rituxan monotherapy is a reasonable tryout for some patients. And so I have on occasion used Rituxan monotherapy as first therapy, either because of patient preference or comorbidities that a particular patient has, or sometimes in very unusual courses where I've followed patients for many years and they have a very slow tempo to the disease. But again, there's no data to suggest that this is the right approach, but it's what I do in my practice.
Okay. In Switzerland, it's quite common to do that because there was a trial from Gilmini who did that, an SAKK trial.
Yeah, I meant no randomized trial versus R chemo versus R alone, rituximab alone.
Okay, very interesting. So there's also some data, or you presented some data about relapsed follicular lymphoma. Is there anything new coming up? New substances, new drugs?
Yeah, absolutely. There are many new agents that are being developed that are exciting, some of which are already tested in early phase trials in follicular lymphoma, some that have been tested in other lymphomas that will be applicable to follicular lymphoma. And I think one of the most exciting agents are the kinase inhibitors, and there's two of them that are far along in development. One is the BTK inhibitor, Ibrutinib. The other is the PI3 kinase delta isoform inhibitor called Idelalisib. Is the name for it. Now has a name. Was Cal-101 GS-1101. They're very interesting agents in that they have a completely different target than chemotherapy or Rituxan. That is the mechanism of B-cell receptor signaling. They have activity in low-grade lymphomas as well as CLL. And there was data at this meeting showing that not only are they capable of achieving responses in relapsed and refractory patients with lymphomas and CLL, but also that they can be added to chemotherapy without any apparent toxicity.
Okay, so this will come, but it's not yet ready.
That's right.
Okay,
that's right. These trials are in phase 2, and the phase 3 trials that are going to be the registrational trials are actually in progress in the United States right now.
Okay, so that's quite far away. And what about lenalidomide? So there's kind of, you said before, we have the rituximab monodata, and we have bendamustine rituximab, then some get R-CHOP still,
that's right.
But what do you do?
So there was a frontline trial at this ASH meeting of lenalidomide and rituximab as first therapy for follicular lymphoma. It was not a trial that was randomized against any other arms, and the follow-up is still rather short compared to Rummel's follow-up, which is almost 4 years. But the response rates were quite high, and at short follow-up, the progression-free survival looked very good. So I think that that's a regimen that bears study. It also is currently being studied against bendamustine rituxan or R-CHOP, depending on the treating physician's preference, in a randomized large trial called the Relevance trial. So it may become an upfront option for for follicular lymphoma, but we're waiting for that randomized trial to be completed.
It's more toxic, isn't it? Lenalidomide plus rituximab, it's probably more toxic than bendamustine.
It depends on the it has a unique toxicity. The same way the toxicities for bendamustine are different than the toxicities for CHOP, the toxicities for lenalidomide are very much different than the toxicities for either CHOP or for bendamustine. The toxicities that are unique to lenalidomide are the flare reactions, which could be somewhat time-consuming to manage early in the course of therapy for the treating physician, but generally are not life-threatening and you can treat through. The other things are cytopenias. Neutropenia in particular, I think, is one of the adverse events that's kind of common with prolonged lenalidomide treatment. But again, not
fatigue?
Fatigue, change in bowel habits. These are symptoms which are, and rash early on are other potential adverse events. But some patients tolerate it just fine. The question is, I think, does it offer us anything used up front that is an advantage over chemotherapy Rituxan combinations? Well, one potential might be the induction of an immune response. Remember, lenalidomide is an immunomodulatory drug, and probably the most important thing that it does is reduce on tumor cells the immunosuppressive ligands that paralyze T cells. Okay, so it may be, if you're killing cells with Rituxan in the setting of an immunocompetent milieu instead of an immunosuppressed milieu, some patients may actually have an active immune response and have a prolonged remission. I'm sure correlative laboratory data will become available to see whether that's happening, but we'll see in follow-up if there are any, if there's any plateau in the Kaplan-Meier curve, et cetera. So I think it's a very active upfront regimen. We need to see the upfront data as they mature in terms of progression-free survival, and we certainly wait for the biologic studies.
Okay, very interesting, but it's not yet ready for the clinic. It's just
it's
kind of
not standard. It's still in trials.
Okay.